All right. Well, hi, everyone. Welcome to our program today, What You Need to Know About Colorectal Cancer Treatments. My name is Stephanie Trong. I am a blood cancer survivor, also the founder of The Patient Story, which I started when I experienced myself so many questions, and all I found was medical jargon and outdated statistics. So, our goal here at The Patient Story is to help patients and care partners navigate life after a diagnosis. So, what does this mean in human terms? We do this primarily through in-depth patient stories and educational programs like today's. We hope to help connect those patients and families to information and understanding about topics like self-advocacy and the latest in treatment options, which we know is especially important in a space like colorectal cancer, where every difference is made in how early someone can get that diagnosis, and also how much people know about what's available to them and what questions they can ask their own healthcare providers. So before we get to our incredible speakers today, we do want to say thank you to Takeda for its support of our independent educational program. That support helps us host more of these, and always for free for our audience. I do want to say The Patient Story retains full editorial control of the content. We also want to thank our promotional partners, the Colon Cancer Coalition. We'll share more about them and their mission toward the end of our program. While we hope you walk away with more knowledge, it's important to note that this discussion is not a substitute for medical advice, so please consult with your own team. And lastly, but really importantly, we really want to hear from you. What can we do better? What do you want to hear about? And so there is a survey that will pop up after this ends in a box, and we want to get that feedback. So please let us know how you feel. All right. Housekeeping is done, and now it is my pleasure to introduce someone who is not only a very known and respected person in the colorectal cancer advocacy space, but someone I'm lucky to call a friend now. So thank you so much, Allison, for joining us today and agreeing to lead the conversation. I'll send it over to you.
Thank you so much. My name is Allison Rosen. I am a 12-year colorectal cancer survivor and very passionate patient advocate. And I'm very excited to be here today to talk to Dr. Kathy Ng about colorectal cancer, some of the latest treatments, and clinical trials related to metastatic colorectal cancer. My treatment consisted of surgery, radiation, chemotherapy, more surgery, and ultimately I have a permanent ostomy. I became a very passionate advocate when I wanted to meet other young people like me that were diagnosed with colorectal cancer, because I felt very alone when I was first diagnosed. So I became an advocate sort of by accident. I was treated in Houston at MD Anderson, and I asked to talk to another young adult. She was very active in advocacy and introduced me to the advocacy space. So now I volunteer with a lot of the national and local advocacy organizations in order to help people. And I get to work with amazing clinicians, researchers, and doctors like Dr. Ng, and help provide the patient perspective for different things that they're working on. I'm going to start by introducing Dr. Ng. She is the David H. Johnson Endowed Chair in Surgical Medical Oncology at Vanderbilt-Ingram Cancer Center. She's also the co-leader of the Gastrointestinal Cancer Research Program and co-director of GI Oncology at Vanderbilt. She's also the executive director of the Young Adults with Cancer Program and co-chair of the NCI GI Steering Committee. Welcome, Dr. Ng. We're really excited to have you today.
Thank you so much for having me here today. And I just wanted to comment, you are so fortunate to be diagnosed with stage 2 because most people, unfortunately, that are young adults are diagnosed at a much more advanced stage. And stage 2 is a very unique setting because it's extremely early in regards to prognosis, but obviously for the majority of patients, surgical resection is curative. Yep. So you are very, very fortunate, and I'm so glad to have you here with us today.
Thank you. And it's interesting because the reason why I'm so active is because I'm alive. So I have a purpose, and my mission is to be a part of things like this so that you can talk about what is out there. So people that might not have access to what I had have access to information that is current and ongoing, so they can get the best possible treatment. That leads me to my first question. What drew you to this field? And can you tell me a little bit more about the young adult cancer program that's a part of Vanderbilt that you run?
Thank you for asking. What really drew me to this program is basically individuals like yourself. I had a very, very large clinic when I used to also work at MD Anderson. I was seeing young patients as young as 16. That was my youngest. These are patients, as you probably know, that do not have an inherited form of colorectal carcinoma. The majority of patients have sporadic colorectal cancer. And unfortunately, they were showing up to my clinic with very advanced stage 3 and stage 4 disease. And as a result, it's really hard not to be able to appreciate all the hurdles that a young adult has to go through in order to go through their treatment with success and with little, hopefully few toxicities. It's really that communication with the patient. And I think that kind of lives with you as a physician.
I know many of my friends that are a part of that program, and many people that have gone through it. And it's just so much, it's needed. So I appreciate everything you're doing for the young adults that are going through treatment, and unfortunately the future young adults that will go through treatment. And you brought up a good point. We'll talk in a second about treatment options and latest and greatest, but you have to treat the patient as a whole. So all those things like the fertility and the body image are so important, along with the chemotherapy and radiation. Mm-hmm. So it's just exciting to hear, and I'm glad that everyone listening to this will hear what you're doing.
Well, thank you. And I want to thank you as well in regards to helping promote education and awareness, because we don't know the exact etiology for why this is happening, but we can continue in the interim to promote education awareness so others can be diagnosed earlier, like yourself.
So on to sort of the current treatment landscape and what is going on. So, I mean, I know as an advocate, I've been involved and I've seen at some of these meetings that progress is being made in treating metastatic colorectal cancer, but it's still challenging. Could you summarize some of the latest and greatest treatments?
So when you're thinking about the treatment landscape for patients that don't have a particular molecular marker, oxaliplatin-based treatment and irinotecan-based treatment are still commonly utilized. And I think we have to recognize that it's still important to be in contact with the patient, because those regimens in combination with 5-FU-based therapy are still really the foundation of basic treatment. But I think one thing that's kind of come about over the past 2 years is that looking at sidedness and recognizing that if you have a patient with a left-sided tumor, which has a better prognosis overall than a right-sided tumor for a non-inherited form of colorectal cancer, so MSI stable patients, if the patient is RAS wild type, and I think once again that goes back to molecular sequencing, the data shows that if you're RAS wild type, you would probably benefit from anti-EGFR therapy in combination if you're considering irinotecan or oxaliplatin-based therapy, and that has been shown to improve overall survival. And that was from 2 ASCOs ago, if I'm correct. But that's still important. Granted, obviously not everybody loves EGFR therapy because it causes a significant rash. But there are benefits to considering that type of treatment. And I do want to mention, once again, for the audience that may not be familiar, once again, a RAS mutation is very common in 50 to 60% of all of our colorectal cancer patients. And now we're getting so specific that we're asking what type of RAS mutation you have in regards to KRAS, and we'll talk a little bit about that. But I think one of the other things that's really important as well to keep in mind is that I want to mention this because I think it's really important when we're not focusing so much on molecular markers. This just came out in JCO, actually. Patients ask me, do I need to have my primary tumor removed because I have metastatic disease? And they think it's like breast cancer where you have to have your primary tumor removed in order to reduce your tumor burden. And that actually does not benefit a colorectal cancer patient with metastatic disease. And there's a pooled analysis that just came out in JCO, but previously there had been 3 presentations regarding this subject matter from countries all across the world, which indicate that you do not need to remove your primary tumor of the colon or the rectum in order to improve your overall survival. In fact, it does not improve your overall survival. And I think that's really important to keep in mind, because sometimes we hear patient stories where they're told that they have to remove their primary tumor. And you should not have to unless you're having uncontrolled bleeding or near obstruction, or obviously high risk of perforation. So we don't encourage that to be completed. And that's literally hot off the presses from JCO. So that's for all comers in general. I think it's also really important to keep in mind for a rectal cancer patient, if you are having some symptoms, we can give you short course radiation therapy that would help alleviate some of those symptoms despite having metastatic disease. So getting back to treatment, I think one thing that is extremely important is obviously looking at the role of HER2. We have seen that basically looking at HER2 amplification, which is present in approximately 4% of our patient population, is very, very important. Although it's a very small number of patients that have HER2 amplifications. So tucatinib is the most recent drug that was approved, which is an oral tyrosine kinase inhibitor of HER2, and it prevents downstream phosphorylation and involves the EGFR pathway. And basically, these are patients that are going to be RAS wild type, most often have left-sided tumors. And the best part about the tucatinib study, which shows you the relevance of having a rare mutation, is it got FDA approved based upon a small phase 2 study. It was not a giant phase 3 study, and I think that's important to keep in mind. And it showed that these patients had, despite being heavily pretreated, they had a great response rate. I think it was 38%. Progression-free survival was excellent, and the overall survival was close to 2 years. So that is one of the newest things to be considered is HER2 testing. We're very familiar with it in gastric cancer, familiar with it in breast carcinoma, but this is the first time really looking at it in metastatic colorectal cancer, and making sure that all patients get tested for HER2. There's also the new drug, deruxtecan, which is an antibody drug conjugate, which is not necessarily new in regards to its presentation, but new in the sense it just received a tumor agnostic approval, meaning that it's approved for not just colorectal cancer, but other tumor types. And I think one thing that's unique about deruxtecan is it can be utilized after the study that was originally designed that resulted in its approval allows you to receive prior HER2-based therapy. So you could have had tucatinib or pertuzumab or one of the older lapatinib HER2-directed drugs, but then you can go on to receive deruxtecan as a single agent. Once again, it does the best in our 3+ patient population. But it has a benefit in that setting as well in regards to progression-free survival and overall survival. And so that just resulted in a tumor agnostic approval at 5.4 milligrams per kilogram. So once again, please test for HER2. I think that's extremely important. In regards to other molecular markers, obviously, there's a lot of interest, as I mentioned before. Thinking about, what is your KRAS status and which mutation do you have? And I think that the KRAS G12C inhibitors are obviously they're more further along in development than the G12D. Granted, the G12C in colorectal carcinoma is less than 5% of our patient population. It's more common in lung cancer, but still, once you identify those patients, they may benefit from therapy. And CodeBreak 300 actually was presented at ESMO last year. And it was part of a phase 3 clinical trial in a previously treated patient population. And they looked at dosing as well. The goal is that we know that the KRAS G12C inhibitors don't work by themselves. They were evaluated by themselves with less than 10% response rate. But in combination with anti-EGFR therapy, so kind of just trying to not only block that pathway at one point, but also at another point, the combination together results in improved benefit for patients. And so although it's not FDA approved at this time, I know that obviously if you've been previously treated, you can obviously inquire about receiving it for patients in regards to patient care, once again, in combination with anti-EGFR therapy. And now they're actually moving forward the G12C inhibitors in combination with chemotherapy in the frontline setting. And I should mention also for tucatinib in the HER2 setting, they're also looking at it in combination with newly diagnosed patients with oxaliplatin-based therapy. So that's really exciting, the fact that we've now found molecular alterations that have been positive studies in the refractory setting, and now we're moving that earlier into frontline therapy to see if that is more advantageous for our patient population. I think one trial that I'm really excited, I really hope it's going to be positive, obviously we don't know, is Breakwater. Breakwater is a phase 3 trial for BRAF V600E mutation tumor types. And that is, still not common, less than 10% of our patient population, about 9% of all of our patients. But, encorafenib and cetuximab was approved once again in the previously treated setting. And then now we moved it up to the frontline setting in combination with oxaliplatin-based therapy. That trial finished enrollment. I'm one of the investigators on that trial, and now there's another arm that's open as well in combination with the irinotecan-based therapy. So I really hope that we will continue to move these rare molecular alteration subtypes earlier on in development, because we can get greater outcomes and hopefully improve and break the barrier of the overall survival, which is currently roughly about 35 to 37 months for the majority of our patients.
So you talked a lot about KRAS, HER2, BRAF, all these mutations, and you talked sort of about personalized treatment and biomarker testing and treatment being driven by that mutation. Mm-hmm. So let's say someone's listening, a patient's listening that's never heard of biomarker testing. Like, why is it important? What is it? Why is it important? And what would you tell them if their doctor didn't necessarily bring it up?
So that's exactly why I mentioned the very first thing for any metastatic patient is they need to ask what the molecular sequencing is. It's critical because, as I mentioned, it helps create, from my perspective, it helps create a treatment plan. So, historically, many, greater than 5 years ago, maybe 10 years ago now, we would just look at all patients that's this kind of standard, all patients are the same for metastatic colorectal cancer, and that's not the case. We know that having a molecular marker can make a big difference. And also it's important because it can actually prevent you from receiving unnecessary toxicities and costs. So the most pivotal one obviously was looking at KRAS and anti-EGFR therapy, such as panitumumab and cetuximab. And that class of drugs, we all know, causes a rash in 80 to 90% of patients. And obviously, if you live in one part of the country geographically, you're also at higher risk for having an allergic hypersensitivity reaction to cetuximab if you live in the Southeast. But that KRAS mutation, which, as I mentioned, is about 30 to 60% of all colorectal cancer patients, they looked at that in a prior study, and if you have the RAS mutation and receive anti-EGFR therapy, it's no better than receiving placebo. So, why would you want to subject your patient to a toxicity, potential allergic reaction, an extreme financial cost if it doesn't benefit them? And I think that's the most important thing to keep in mind is RAS was just the beginning, and we are now identifying all these new molecular subgroups, such as HER2, such as BRAF, and microsatellite instability high is obviously extremely important in regards to the role of immunotherapy. And all patients should definitely, once again, that's another small patient population, less than 5% of our patients, but that's where immunotherapy may, because it doesn't benefit all patients, but it may benefit our MSI high or deficient MMR patient population, where immunotherapy can have a significant role in potentially curing them. I do want to mention, I think it's very important to keep in mind that molecular sequencing can be obtained from tissue and blood. And it's important if you're newly diagnosed to send off that tissue as soon as possible before it gets sent off to some warehouse, because it can't sit in the pathology department for forever. And the tissue molecular sequencing, depending upon which panel you use, can look at hundreds and hundreds of various molecular alterations or mutations or amplifications, etc. But you can send off blood sequencing, and yes, the tissue sequencing does take longer for reasons. Obviously, if you're looking at hundreds of molecular alterations, but the blood sequencing, yes, it's quicker. You can get it back in within less than 2 weeks, but the problem is that you're only looking at like 100 different mutations relative to the 500 or so plus potential molecular alterations. And some places still do it in-house, but the majority of institutions send it out to other third-party companies now. So I think it's important to keep in mind, not only ask your doctor about it, but ask for tissue and blood to be sent off, because that information from blood can be critical in trying to identify a clinical trial for the patient as well. And I cannot emphasize enough the that specifically is involved in anti-angiogenic therapy, anti-angiogenesis or anti-VEGF therapy, vascular endothelial growth factor therapy, means it's working on the blood supply. And our goal basically for this class of drugs is to reduce the development of metastatic disease, because a tumor needs a blood supply to survive and thrive. And this drug is an oral agent, which specifically blocks receptors 1, 2, and 3 of the VEGF pathway. And it was originally already approved in China in the third-line setting based upon a phase 3 trial called FRESCO that was conducted overseas. And FRESCO-2 is specifically to try to not only address the practice patterns of what we are doing in the United States, which is continuing bevacizumab for front-line and second-line therapy, but also trying to ensure the majority of patients had received anti-VEGF therapy as prior treatment, which was the case. 97-98% of patients that participated in FRESCO-2 had received prior anti-VEGF therapy. FRESCO-2, when we designed it, really allowed almost all comers. You were allowed to have received prior TAS-102, or as you may know it, Lonsurf as the brand name. I call it TAS-102, and that was before the approval with bevacizumab in combination. Or they could have received regorafenib, which has been approved for quite a while now. So patients may have been exposed to either of the drugs or both of the drugs. So we really, it was a trial that really allowed almost all patients to participate. And after a median line of 4 prior lines of therapy, basically this drug as a single agent when compared to placebo, it was a 2-to-1 randomization. And I know some people criticize the fact that there was a placebo arm, but when you think about it, there's no standard of care for 4th line therapy or 5th line therapy. So there was nothing to compare it to. Some people say, oh, can't you just go back to 5FU? But the reality is patients have already progressed through 5FU. They're not going to be receptive to 5FU. So the primary endpoint was met with an improvement in overall survival for our patient population, and as well as improvement in progression-free survival. And the FDA approval now is based upon the results of both FRESCO-1 and FRESCO-2. So it allows patients to receive oral fruquintinib as a potential option for 3rd line and beyond therapy. Overall tolerated fairly well as a class. Hypertension is an issue with this class of drugs, but treatable. And so it just got approved in November. And so we are very pleased to see the FDA approved it. It's pending EMA approval, I believe still, as well as approval in Japan. And after that, it will hopefully be approved internationally so all patients can get access. Because once again, people are always asking me, well, how do you choose between this drug and other drugs? And the reality is you need to make sure you have drugs available to the patient overall at the end of the day. And I don't, it's like saying, do you prefer FOLFIRI or FOLFOX? The reality is you're going to get both drugs at the end of the day. And it just matters how well you tolerate it and how, that's how you derive the best benefit from it. So I try not to make it very competitive. I don't think it benefits anybody. I think it's important to recognize there's a new drug on the market and it's available for patients. And it does not require IV therapy. It's an oral agent.
So the question then, from what you just said, is where do you see it sort of fitting in with the current therapies that are available for metastatic colorectal cancer? And could there be any potential to use it as a maintenance therapy?
Yeah, so that's actually being investigated. That's my understanding as a maintenance therapy, because obviously it makes a lot of sense since majority in the United States for maintenance therapy use capecitabine or Bev or 5FU and Bev, so it would make sense to use this potential maintenance therapy. So I know it's being considered. When thinking about it, relative to its other agents such as regorafenib and Lonsurf plus bevacizumab, the reality is that I look at the patient, I talk to the patient. Lonsurf plus bevacizumab, I utilize quite a bit. Some patients, however, they're tired of coming in every 2 weeks for their bevacizumab, and they just kind of want a break, and I think that's very reasonable. Also, Lonsurf or TAS-102, one main thing, and once again, it's a matter of communicating with the patient. They're at risk for myelosuppression, so their white blood cell count can drop. That's a known side effect of that class of drugs as well. So you have to make sure you have a patient that's compliant and not take the medications incorrectly, because obviously you don't want a neutropenic patient walking around and putting them at risk for other infections. So there's certain patients that I don't necessarily offer TAS 1 or 2 on a regular basis. For instance, I had an elderly patient, this just happened recently, whose platelet count is never above like 100,000. He had been on a lot of therapies from many years ago and came to me for a second opinion. And no matter my best intention, I would be a bit hesitant to give him TAS 1 or 2 in that setting because I know his counts are going to be a problem in regards to his platelet count. And so that's why I chose fruquintinib for him first versus the TAS 102. So it's really a discussion with the patient. Once again, I don't try to choose one versus the other. I talk to the patient about the potential side effects and see what they're willing to endure.
Well, it's all about shared decision making, right?
Correct.
you
so.
know about everything that's going on, and having that conversation with your physician is so important.
Very, very important.
So I think with the time we have left, I want to sort of go into emerging therapies and some other clinical trials that you might want to discuss.
Number one, I encourage all patients to consider participating in a clinical trial. Currently, the enrollment across the United States is about 7% for non-NCI cancer centers. For NCI designated cancer centers, it's up to 20% in regards to enrollment, and that's from a recent publication. But still, we cannot make breakthroughs until we get trials completed. So I think that's really important to keep in mind, and not all trials involve a placebo. So very, very important to keep in mind. Yes, for the metastatic setting, I think there's a few trials that you should really keep your eye out on. For an MSI high patient population, we should be getting some updates soon regarding Nivo/Ipi. They presented their data at ASCO GI looking at Nivo/Ipi in combination versus chemotherapy, and that was superior, but it was a very rapid abstract presentation, so we don't have further details. And I believe at this year's ASCO, when I looked on the website, I think there's going to be an update, so I look forward to that. Because is really 2 immunotherapies better than 1 for this patient population? You have to think about toxicity, so it will be interesting to see. Other trials, yes. So you mentioned the PUMP trial, EA2222, if I'm correct. That is a new NCI-sponsored study specific for newly diagnosed patients, and they're allowed to have, I believe, up to 6 months of prior systemic therapy beforehand. Once again, for newly diagnosed, so only frontline therapy, they will either get randomized to having the pump versus just continuing chemotherapy. And so that trial is an important trial. I think will really answer that question, because we know all the data from Memorial Sloan Kettering, but can we validate and replicate that data outside of that institution? And especially if you do an earlier line setting. The Erasure trial, I think, is also a nice trial as well. That's another NCI-sponsored study that you mentioned, which is looking at the role of whether or not you should do stereotactic radiation therapy or ablation or some type of liver-directed intervention in order to improve the overall survival of our patients. So I think that's also a very important trial. And then also the trials of Mountaineer 3, as I mentioned, with tucatinib in the frontline setting, and then looking at the role of sotorasib, or the KRAS G12C inhibitor, in the upfront setting. But keep in mind, that's not the only KRAS G12C inhibitor. There's other companies as well with their KRAS G12C inhibitors from Mirati and Loxo Lilly. And so sotorasib is the first generation, but sometimes the next generation may be even better. So, I'm looking forward to those trials as well.
So, I mean, I'm looking forward to hearing about, updates on some trials, but then some new stuff I'm sure is bound to come out. And we sort of already touched a little bit on the importance of clinical trials, but I wonder if there's any sort of take home message for the patients or anyone that's listening.
Yes.
About clinical trials and the importance of participation in clinical trials.
I think that all patients should consider getting a second opinion if they've not been offered a clinical trial. Obviously, there's some selecting settings where there is no clinical trial available, but that you should have that discussion with your caregiver or your provider on your first meeting or your second meeting. It doesn't take that long to get a second opinion. You want to look at all your options. You want to feel informed. And I think that's extremely important as a patient. And that really is the best way to optimize your care. Because it is very, very distressing to me as a medical oncologist when I met a patient who got 1 cycle of chemotherapy before they walked in my office, and they would have been a perfect candidate for a clinical trial.
Yeah.
And then they're automatically disqualified.
Well, it's like knowledge is power, right?
Yes.
And I think that there's so many amazing trials and there's so many amazing places to go now that the first step is educating on clinical trials. So there's a lot of advocacy organizations and organizations, institutions that are trying to educate on what is a trial 101, and then having that conversation with your doctor, making sure, like you said, it is happening. Because
Right.
it's so important, because the last thing you want to do is disqualify yourself for a trial because you did something here versus going here. And I know personally, I got 3 different opinions before I actually decided on where I was going to get treated because of my age. So
Yeah.
younger people, especially, talk to as many people as you can, educate yourself as much as you possibly can. And I think this conversation is an amazing start for people to better understand that there are options. So last home message, take home message I want you to give those listening: if you're diagnosed with metastatic colorectal cancer, what sort of message do you have for these patients? Like, I always tell them, your life is not over. There are treatment options out there. I know quite a few people that were stage 4 that are now in remission.
Yeah, I would have to say that I hear time and time again that they've been given some poor prognosis of 6 months to 8 months to live, and I just think that that's very discouraging, and that's not the right approach. The reality is that we have so many new options available to patients. The science has advanced so much that do not think so negatively. And if you hear that kind of negative attitude on your first meeting with your new physician, you need to go get a second or a third opinion. I'm not saying delay your treatment by months, but I'm saying give yourself 2 to 3 weeks to make an informed decision and go get another opinion.
Yeah, I mean, I agree, because the relationship you have with your oncologist, your surgeon, your care team in general is the most important thing. It is the difference between a lot of different things that can happen along a journey.
Correct. It's also important for people to keep in mind there's always hope.
Yeah.
It's extremely important to keep in mind.
And I think I got hope, number one, from talking to someone else that had gone through it, because at that point I was originally diagnosed with stage 3, and they said it was about to break through my colon wall, and there's so much communication, so much going on, especially when you're first diagnosed, that talking to someone else that's gone through it. I help introduce people to stage 4, stage 3, stage 2, stage 1, because I think it differs with every stage. But I know people that are now 20-year stage 4 colorectal cancer survivors. And that's the hope that I think that someone needs.
Yeah, now your medical oncologist is key. I mean, the radiation oncologist and surgical oncologist, they're always there. But the main person of the captain of your ship, besides your primary care doctor, is your medical oncologist.
Yeah, and you are an amazing captain of the ship. I know from hearing from many people and just knowing you for as long as I have. So thank you so much for taking your time today to talk to us, and all the people that will be listening. This information is invaluable. And again, I know I appreciate it. I know everyone listening is going to appreciate it as well.
Thank you so much.
All right. Thank you so much, Dr. Eng, for all that you do, not only in terms of the research, which of course is critical to advancing care, but also to the way you're thinking about patients as you do all the work that you do. And thank you, of course, to Allison for the work you do in advocacy and for leading today's program, which wouldn't be the same if we didn't have that patient perspective guiding it. Wrapping up our thank yous, again, thank you to Takeda for supporting our educational program, Independent. This support, again, allows us to keep doing these. And also thank you to the Colon Cancer Coalition, which is our promotional partner for this. It's an incredible story, very personal mission, founded by someone who lost her sister to stage 4 colorectal cancer. And so this year, the Colon Cancer Coalition is celebrating its 20th, 20, Get Your Rear into Gear fundraiser in the Twin Cities in Minnesota. And it has so many other rides and fundraisers happening across the country as well. So some of that we're showing now, and we'll also drop those links in our email. But this really, these fundraisers highlight the need to screen and raise awareness of colorectal cancer. The organization says it gives more than $1 million every year to local community programs to help fill that need. So please go check them out. All right. Lastly, thank you all for joining us. We hope that you are walking away with a better understanding of what's out there something to talk to your own healthcare team about. And we want to hear from you. So again, please fill out that survey that's going to pop up shortly after. And if you miss it, we will send that in a follow-up email. All right. So thank you so much for joining us. We hope to see you at a future program. My name is Stephanie Trom with The Patient Story. Take good care.